This is a case of cataract surgery in an 85-year-old female patient. The patient presented weak mydriasis due to floppy iris syndrome. The optical biometry by LensStar showed an axial length of 21.84 mm and estimated an intraocular lens of 23.5 diopters. And also showed a reduced anterior chamber depth, measuring 2.49 mm. In order to avoid possible strokes to the iris. In these cases it is preferable to fill the anterior chamber with viscoelastic before proceeding with the main incision. Taking appropriate care and time with the architecture of the incision to avoid possible iris prolapse. The digital planning of the Verion system assists in the positioning of the main incision, side port, as well as the capsulorhexis. In this case coinciding with the visual axis and in a diameter of 5 mm. The anterior chamber is then filled completely with viscoelastic to facilitate the execution of the capsulorhexis. Special care must be taken so that there is no loss of pressure in the anterior chamber during this maneuver, which can lead to possible complications. Remember to add viscoelastic to keep the anterior capsule always flat whenever it is needed. Attention to keep the capsulorhexis properly centralized with the surgical planning, and in a continuous and curvilinear fashion. Careful hydrodissection and rotation of the nucleus inside the capsular bag is then performed. After this stage the phacoemulsification of the nucleus is performed. In this case with the technique of dividing and conquering. Note that the pupil has reduced its diameter and the phacoemulsification probe must remain in the central safety zone. Be very careful not to inadvertently vacuum the pupil edge or the anterior capsule of the lens. After the aspiration of cortical remains, the intraocular lens is mounted on its proper injector. Injection of viscoelastic to open space inside the capsular bag is fundamental before implanting the intraocular lens. Note that the floppy iris syndrome may complicate the procedure even in the moments near the end. After repositioning the prolapsed iris, it is possible to inject the intraocular lens into the capsule bag without major problems. The final step involves meticulous aspiration of the viscoelastic behind the intraocular lens and in the entire anterior chamber. Also be careful to remove any viscoelastic material that may be in the iridocorneal angle. This maneuver is very important to avoid increased intraocular pressure in the postoperative period. Finally, you should check whether the incision is watertight. And that's it. Thank you very much for watching.